Good evening and welcome to First Say Chats by Dr. G. I'm Dr. Adana Grandison, a physician in Barbados, and your hostess for this evening. First Say Chats by Dr. G is a live podcast that provides listeners with a unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. And this evening, our episode is entitled HIV and AIDS Education and Empowerment Ending the Stigma. And our guest is Dr. Brendan Larder. Dr. Larder is rejoining us this evening. And as you know, Dr. Larder is a PhD, has a PhD in virology from Cambridge University in England. His career has focused on HIV therapeutics, molecular diagnostics, and pharmacogenomics during 35 years in academia and the pharmaceutical industry. His pioneering work on HIV drug resistance paved the way for the development of successful HIV drug combination therapy. He has numerous seminal scientific papers that have been cited over 20,000 times worldwide. Good evening and welcome back, Dr. Larder. How are you doing?
Yeah, I'm good, thanks. Good evening.
Good evening. Dr. Larder, now, HIV and AIDS has been seen worldwide as almost a taboo topic, especially when it first presented on the world stage. However, as time has gone on, with more education, persons have been able to gain a better understanding about this disease process. And so this evening, I thought it would be best, given that after all, you are a virologist, to really get the scientific end of HIV and AIDS as we know it. So I'll start off with what is HIV, Dr. Larder?
Okay, well, HIV is a virus. It's a retrovirus, which I'll come on to in a minute. HIV infection is really an infection that causes certain blood cells to deplete. And these are specific important blood cells called T cells or CD4 positive cells.
Right.
These cells help the immune system to function. They're kind of the soldiers in the immune system. So without those cells, or with a diminished number of those cells, the immune system doesn't function very well. So basically, HIV attacks these immune cells in the blood, and causes a weakening of the body's defenses from infection. And this can take many years to actually become apparent. But without treatment, people become more and more susceptible to so-called opportunist infections, for example, tuberculosis, some cancers, PCP. And this, untreated, can lead to death. And in that state, when the CD4 T cells become low, typically a count below 200, then the person would be classified as having clinical AIDS.
Right.
So HIV is the virus, and AIDS is the condition that is really a long way down the line when a person becomes severely ill from the infection.
Okay, so I'm glad that because that was going to be my next question, really. What is AIDS? Because a lot of persons generally use these two terms interchangeably, but I'm glad that you actually brought up the differences in terms of the understanding between the virus itself and certainly then the disease process or the syndrome associated with a severe decline in the immune system functioning. I wanted to go on to how does a person get AIDS?
Well, a person gets AIDS when they've been infected with HIV for a number of years, but they get infected by HIV through unprotected sex, from the use of needles, anything that really can get into the blood. So transfusions as well, if the transfusion contained the virus. Do you want me to talk a little bit and go on to the actual retrovirus itself and what it is?
Absolutely, absolutely. Go ahead.
Well, the virus itself was first discovered in 1983 by
Hmm.
some French researchers, and this was because they were looking for the cause of this strange syndrome that had been discovered originally in San Francisco in the States around 1981, when particularly homosexual men were seen to be getting some becoming infected with some very unusual infections like PCP and with unusual cancers. And it
One
seemed
second,
like it
Dr.
was
Lardo. What is PCP? Just for clarification of our listeners, so that
it's pneumocystis.
right,
It's a kind of a
a
it's
respiratory illness.
yes,
Okay,
that's right. It
okay,
affects the
right,
lungs.
right,
Yes, it's a very uncommon normal illness. Normally, it's very uncommon because our immune system can fight it off.
right. Okay, great.
So
I just want to bring that clarification. Go ahead.
yes, the virus itself is classified as HIV 1, type 1 or type 2, but type 1 is really the major dominant type that is seen around the world. Um, the virus is called a retrovirus, which means that it replicates its genome in kind of in reverse.
Hmm.
What does that mean? Well, the genome is RNA. So that if you think of genomes, our genome is DNA. This is RNA of about 10,000 bases long, and there are two copies of it in each virus particle. Now, so for example, the COVID coronavirus is also an RNA virus and has about 30,000 bases in its genome. But there's some big differences between them. The A retrovirus like HIV goes through a very peculiar replication cycle, which is unique to this virus. So it converts its RNA into DNA and then back again into RNA. And to do that, it needs some very specific, its own enzymes or
Right,
like little powerhouses that will do that. Um, One is called reverse transcriptase, the reverse bit turning the RNA into DNA. One is an integrase, which is an enzyme unique to the virus that helps to integrate that DNA into our own cell DNA so it can then make more copies. And another one is a protease, which helps chop up the resulting proteins that are made in this powerhouse from this little factory of viruses. So it has these unique functions that when the virus is recognized as a retrovirus, immediately some light bulbs went on in the world of science and virology because it became clear that there were probably weaknesses with the virus that where drugs could be produced. Interventions, and specifically the reverse transcriptase or RT, the protease, and the integrase, and they really inhibitors of these three unique and essential functions for the virus. If these are blocked, the virus doesn't replicate. Um, and the drugs that we have today are based around inhibitors of those three enzymes.
right. So you spoke about exactly what this virus is. You spoke about the fact that we can find this virus in any biological fluid, any body fluid, whether it's blood, semen, vaginal fluid, breast milk. It can also be transferred from persons sharing biological instruments or what we would call needles. So if you are sharing needles for drugs, and also sexual transmission because of some of those biological fluids are found during a sexual encounter. But we can also have mother to child transmission, and previously a lot of persons would have heard of cases where it could have been transferred via a blood transfusion. Now, here in Barbados, that likelihood is very low given the fact that we run a very robust testing regimen on persons who are to be subjected for blood transfusion as well as their donors. So we would find out exactly what that sample of blood contains. And it's not just for HIV, hepatitis B, hepatitis C, and some other viruses, along with HIV, to determine if this blood sample is safe to give to someone. So you spoke about the virus, and it sort of seems as if it has some commonalities between um, coronavirus and HIV virus in that it's unable to make its own virus particles over and over again. So it requires a powerhouse, which is sort of our cells, and it uses our cells along with some of these enzymes based upon what you said to essentially get more of that virus. Am I understanding you correctly?
Yes, that's correct. So the virus, like a coronavirus, is a, a package of essentially its own genome, and the virus doesn't have a mind or a soul or anything like that. It's just a little package that is able to piggyback into our cells and replicate itself. So if you think of it those terms, it's a bit like cars being produced in a factory.
Mm-hmm.
Same cars coming out all the time. Although I'll get onto that because it can change a little bit. Um, but by going through that process and because of the specific or the particular cells that it latches onto and gets into and infects, that's what causes the trouble because those are the T cells, the CD4 positive immune cells. And by going through that replication cycle, it kills the cell. So
Right.
the virus itself is just a package of the genome with proteins around it, with a membrane around it, and proteins stuck through that membrane that are there to latch onto new cells when the new viruses are made, and that basically is what the virus does. As I say, it doesn't think, or it's not a thing, it's not a being or anything like that. It's just there to infect cells, hijack the cells, and then make more copies of itself.
Okay. So you stated initially that there is HIV and there's AIDS, and AIDS is a syndrome that develops when the count goes low. Now, we have often heard persons stating, I don't feel any different. There are no symptoms associated with HIV, or so they think. Tell us a bit about this sort of pseudo asymptomatic time that where you don't essentially have any symptoms, but you are still, as you said just now, replicating and forming more virus. I actually see a question here in the message blog saying, what is the window period of infection in HIV? And does SARS-CoV-2 also have a window period? So I'm going to put those two questions together for you. Go ahead.
Right. Well, the infection period with the the coronavirus is with SARS-CoV-2 is very different. Really, it a typical respiratory virus like coronavirus will go through a cycle quite quickly,
Right.
infect and kill cells. So basically, in the replication cycle in a person, it may be the whole infection, the disease could be over within 14 days or so. The
Right.
time when a person becomes infectious, where they have detectable virus, is maybe about probably 3 to 4 days after they become infected. And if they don't have symptoms, and this is again with COVID, they
Mm-hmm.
still can be infectious and they can still pass that on. And so, by contrast with HIV, the infection takes a very interesting course. So, the initial infection is called primary infection, where the virus will enter the body by all those routes that we discussed, or any of those routes that we discussed. It'll blast infect CD4 positive T cells and will produce a lot of virus early on within a day or a few days. And that's early syndrome, which is usually not noticed particularly. It certainly isn't picked up usually by medical intervention. the person who's infected might feel like they've got some flu, they've got a fever, or they just don't feel very well for a little while. And that's that initial burst of virus infection that then, usually because of the immune system, will disappear right down, not go away. But during that initial stage, if you were to measure virus, and we can talk about how we can do that in a minute,
Absolutely.
in the blood, you'd find really quite high levels during that primary infection, that acute infection. But that disappears, so that's not a way really of measuring HIV infection, not normally anyway. Then what happens over the next few weeks during infection is basically the person infected feels well, doesn't think anything more of what's happened, but their immune system starts to respond to that infection.
Mm-hmm.
So antibodies then are produced within about 4 to 6 weeks, and against the virus, and that helps to quell, if you like, or dampen down the infection, that initial infection. Those antibodies are very specific, and we have tests that can detect them. So after about 6 weeks of infection, even though a person can feel completely well and fit and healthy, an antibody test, which is usually a blood test, will detect antibodies that have been basically raised or have appeared because of the virus in the blood. And that's a key sign that the person now is HIV positive and is infected, but with very, very low levels of virus.
Right. I'm actually glad that you brought that up because in that acute phase of just essentially past the primary infection, so the first essentially, let's say 6 weeks, you can have quite non-specific symptoms that you may not even associate with possible exposure and the possible replication of that virus. And then what persons may appreciate is that they almost appear as if they go back to normal. That little flu or that bug went away and everything appears to be normal on the surface, but in the background, the virus is continuously replicating and you're getting a bit more virus being loaded up, and you're also trying to mount an immune response, and more of these immune cells are being infected, right? And
That's
I'm glad that
correct, yes.
I'm glad that you brought that up because that's why it really is important that certainly if from a clinical standpoint, because I know you're more on the therapeutics and academia end, but from a clinical standpoint, it's extremely important for persons if they do believe that they may have even had an exposure during that period to certainly investigate and to check. So you started off talking about the antibody test, but are there any other tests that can be used certainly to determine if a person is HIV positive?
Well, there are. Let me just backtrack a second, because the point you said about people feeling well and not getting tested is a really good one. And looking at the latest or the most up to date statistics for Barbados in terms of HIV infections, it's currently estimated that there are about somewhere around 3,000, maybe just under 3,000 people infected. That's about 1% of the population. And it's nearly 50-50 male and female. It's slightly more male than female. This is in Barbados. But the actual status in terms of the antibody positive status is only known for around 2,400 of those. That's about 90%. So not everybody who's infected has had a test and knows they're infected.
Right.
And also of those people, there's only about 50%, well, of the total infected that actually are receiving any therapy. So those numbers show that the situation could be improved. More people could be detected as being infected, and more people could be treated as well, and that would lead to less problems and complications later on with those people. So the test, yes, once you've gone past the initial stages and a person has been diagnosed using an antibody test, then after that, decisions, I guess, are made clinically about whether the person then would start treatment on antiretroviral drugs. And really now in the WHO and I know in Barbados and worldwide, the really approach is a treat all approach. So once someone has been found to be infected, um, the strategy really is to say, right, that anybody who's infected should be treated. But bear in mind that only about 50% of people in Barbados who have HIV infection are currently being treated. So what happens then? Well, you can do run what's called a viral load test, and this might be kind of familiar territory when people think about everything's being discussed at the moment. It's very topical about PCR and COVID. So the viral load test is basically an RT-PCR test, which is basically identical to, or very, very similar to the test that's currently used to detect COVID infection.
Right.
And that test is a very sensitive test. It detects the virus nucleic acid, the RNA. So it doesn't detect the virus itself, but it detects the specific copy numbers of the RNA as a kind of surrogate, if you like, for the actual virus itself. As I say, it's very sensitive, and this is usually done with blood plasma samples. And the kind of terminology you might hear about viral load tests is detectable, undetectable,
Absolutely. Which I
or
wanted to
and
bring. Go ahead.
or limit of detection. And limit of detection is generally now with these tests, because they are very sensitive, less than 50 copies, genome copies per mil of plasma. So if
So
you
that's
hear things like undetectable, which is good if you're being treated, that's what you want to hear. That means that your viral load is very low and it can't be detected by these very sensitive RT-PCR tests.
Dr. Larder, I just wanted to take a little bit of a back step in terms of really explaining what does the PCR test do? Because we keep hearing about a certain amount of copies, CT values, all these types of terms, but yet, what really does the PCR test do? How does it operate? How are we able to discern if something is present
Okay,
from a
well, the PCR test is a bit like an instrument or a test to quickly find a needle in a haystack. So
Mhm.
if you have a needle in the middle of a haystack, the PCR test it has in the test there are very specific small pieces of DNA that can
Mhm.
latch on to the after the RT step. The RT step turns the RNA into a DNA strand. Then there are things called primers which basically latch onto the specific bit of DNA that is the virus DNA, and then through a number of cycles, PCR is polymerase chain reaction, so it's like a chain reaction kind of. If you imagine exponential growth in something, it's an exponential growth of the chains by continually heating and cooling, and then making more copies and more copies of this piece of DNA. It can be expanded up into a massive amount of copies from a few to millions,
Right,
and then we have detection procedures in the lab that can be used, fluorescent tests and things like that that then the instrumentation can pick up specifically how much of this amplification has occurred at a specific time, and then
right.
convert that into numbers of copies of the viral genome per mil of plasma. So it's think of it as a chain reaction. So two copies goes to four, four to eight, eight to 16, 16 to 32, etc. I'm not going to do any more. Um, but it very, very quickly and in a few hours can become millions of copies that are much more easily detectable than trying to detect that one needle in the haystack. The needle then becomes the haystack, and so it's much easier to actually visualize and see.
Right. So essentially, if you had a very large needle to begin with, you should have a large signal at the end after the specified amount of time, versus if you had a very tiny needle or a piece of that needle, you would have a very low copy. Is that it? Or is it the
Or
other way around? Because we keep hearing about low viral load, and with COVID, I just wanted to bring the parallel so persons are absolutely clear when we hear things like low CT values or we hear low viral load, are they really the same thing? So after a specified amount of copies, you should have more of that sample present. But if you get to that amount that would cause a color change or a fluorescence to be picked up by the instrument, then certainly you had a large amount to start with to begin with. Is that correct?
well, yes. I mean, so think of it as rather than one or two needles in the haystack, but 10, 20, or 30, or 100, or 10,000.
Right,
So you don't need to go through too many amplification steps to
right,
then make a lot of that.
absolutely,
It's interesting with the HIV viral load test. It's it's very clearly a quantitative test,
right,
which means that a number like 60 or 100 copies or 1,000 copies or 10,000 copies or 359 copies is really quite accurate. The COVID RT-PCR test is less. It's accurate, but is not as really as quantitative, just for technical reasons.
right,
So with the PCR for HIV, I don't think we really talk about CTs, which are cycle thresholds, but we talk about proper copy numbers. And the other reason for that is because of the viral load with HIV can be related back to a volume of plasma,
mm-hmm.
whereas with COVID, if you think of the samples, there's kind of scrapings of cells and bits of debris, so it's very difficult to, in a quantitative way, relate back the number of copies or the amount of amplification of that genome of the virus that you see
Right,
to a certain amount of material, if you like, that came from the person that was swabbed. So
yeah,
that's kind of the difference. It's kind of the material
right,
that's being used and analysed, and whether the tests are quantitative or kind of semi-quantitative.
right, great. How important is viral load and CD4 counts for monitoring a person who has HIV infection?
Well, I would say that I mean, initially, you would hope if you were someone was starting to be treated had no symptoms, and had a relatively low viral load, but say detectable, say in the thousands or something like that, you would expect that the CD4 count would be quite high. It's certainly in the many hundreds. Um, Once a person is treated, basically the aim of treatment these days is to reduce that viral load to undetectable levels, which I mentioned before, which is generally below 50 copies, and to maintain it. That's the aim of treatment. So then there'll be little chance of disease progression or actually of transmitting the virus. And there would be a much better chance of preserving the immune system or an immune function of the person who's infected. Now, so CD4 counts then really are not too relevant unless something goes wrong with the therapy. If something
Mm-hmm.
goes wrong with the treatment, those CD4 counts might start to drop. I mean, I'm not saying you shouldn't monitor them because they are routinely monitored just to make sure everything's okay. But if they
Right,
start to drop, then clearly there's some problem, some issue with the therapy, and uh, other interventions or different or additional interventions would probably need to be considered, an investigation of why that CD4 count has dropped. But it's usually, if it does drop, it usually goes hand in hand with the viral load increasing, so going up. So you see both things happening: viral load increase, CD4 decrease, which
right,
makes sense really because it means more virus, less CD4 cells because more cells are being infected and killed.
right. So essentially, the virus is overwhelming the system.
Well, yes, correct, and in the absence of treatment, that's really what's going to happen over the years. I mean, a patient would, or a person who's infected could be infected for a number of years with no symptoms at all,
Mm-hmm.
but with no intervention or no treatment, then gradually those CD4 cells would start to decline, the viral load would increase, and then they will start to become ill and with AIDS and some of the opportunist infections that we talked about before.
Okay, and I'm glad that you spoke about that because the CDC, for instance, has really defined or placed a classification system for HIV infection in terms of three stages, where stage one is considered to have a CD4 count greater than 500, and the CD4 count for stage two is between 200 and 499, and then stage three, or AIDS, is classified as a CD4 count less than 200, or you can have, from a clinical standpoint, a documentation of some AIDS defining condition, which you spoke about before, like the TB or a PCP. Now, you've been mentioning quite often the importance of treatment. So I wanted to move over into your domain, which is treatment. So tell us about the drugs that are in the market and how they have changed over the years, and what is the benefit of some of these drugs?
Okay, well, as I mentioned before, the drugs that have been developed um, are all based on targeting or stopping certain essential parts of the virus working. So that would be the reverse transcriptase, the protease, and the integrase are the main real targets that we see the drugs come from now. And actually, in the past, the first drug that was developed and the first class of drugs that were developed to try and have some impact on HIV and AIDS were the so-called reverse transcriptase inhibitors or nucleoside inhibitors. The nucleoside is a building block of the chain of the genome of DNA or RNA. And the most obvious thing to do at the time, and this was back in the 1980s, was to find nucleosides that were not exactly the same as the ones that are used in the building blocks, but mimic them. So they were kind of mimics, and they also would stop the chain growing. So that was the idea, and the first drug that came out of that was AZT
Mm-hmm.
back in, I think, licensed in 1987. So that was a single reverse transcriptase nucleoside inhibitor that was developed at that time, and it was thought because generally with viral infections and bacterial infections, one drug really once the drug would inhibit the stop the virus replicating or bacteria replicating to a large extent, um, then the drug worked and it stopped the infection. The problem with the drugs were that singly they didn't work, and we could come on to drug resistance in a while. But
Right.
anyway, the first class of drugs that were developed were the so-called reverse transcriptase nucleoside inhibitors. The second class also targeted the reverse transcriptase, and they were found by just kind of random screening of large numbers of basically of molecules, and
Mm-hmm.
these were the so-called NNRTIs or non-nucleoside RT inhibitors. And once they were discovered, this class of drugs, and that involves a drug called efavirenz, which is used today. It was found that they actually didn't bind to the actual polymerase to the site that caused the elongation of the chain of the genome, but they bound on the enzyme somewhere else, but gummed it up. They basically stopped it working, but by sticking in a little crevice and bunging it up. So these were two drug classes that were aimed at the same enzyme, the same RT, but actually worked in different ways. Then after that, and then what happened was that when it was found that a single drug by itself didn't really work in therapy, these two classes were used together in dual combination therapy, which didn't work very well either. And after that, not for want of trying, but it took a number of years for researchers to discover and develop inhibitors against the protease enzyme and against and really latterly against the integrase. The integrase was very tough nut to crack, but it was very worthwhile and has been reaped real rewards, which we can talk about in a minute. So basically, those are broad classes of drugs, four of them, if you like: nucleoside RT inhibitors, non-nucleoside RT inhibitors, protease inhibitors, and integrated inhibitors that are really all around and have been around since 87. The protease inhibitors developed in around about early 90s to 95, and then integrated inhibitors more in the early to late 2000s. So that's the kind of chronologically ordered drugs and what they are. But they, as I said, and this is really to do with resistance, they have to be used in combination. So, for example, with the non-nucleoside RT inhibitor nevirapine, which was one of the first of that class that was discovered and used as a therapy in people, it was found that it would work for about 2 weeks, and after 2 weeks, it became totally ineffective, which was kind of shocking. AZT became ineffective within about 2 or 3 months, which again was shocking. And it meant that some very radically different treatment strategies had to be evolved and worked out through clinical trials and a lot of patients, actually, in terms of doing the research, and a lot of people actually volunteering to take those experimental drugs and combinations. But now we've got to the point where the drug combinations, either 3 drugs or 2 drugs, work very well in terms of suppressing the virus.
Well, you just actually stepped right into the next question that I wanted to ask. If someone is on antiretroviral medication, can they still transmit HIV to others?
Well, yes and no. With regular viral load checks and with very strong combinations and taking the medication absolutely on the dot how they're prescribed, which are usually one tablet now daily, not missing them, not forgetting to take them when you go away for a weekend or when we're allowed to go away for weekends and things like that. Take the drug all the time, have regular viral load checks, and if your viral load is less than 50, so it's suppressed, completely suppressed, there's good clinical data to show that it's very, very hard to transmit the virus. So that's really good news. So really, suppression is the goal for a number of reasons, which is to stop transmission, to stop immune and disease progression in the person, and to keep that person well for many, many years.
Right. I see another question here in our message room. Why has there not been a vaccine developed against HIV?
It's a very good question that I hadn't really anticipated. The HIV is quite. It's unlike, say, flu or other respiratory viruses like coronaviruses and COVID. It's a very insidious, long infection where the virus can hide away, and it's also difficult to find the right kind of molecules that will provoke an immune response that can stop the virus replicating, basically, and stop it infecting cells. And it has been tried for a long time, and even using the vectors or vehicles. So, for example, the Oxford AstraZeneca vaccine, which is based on a harmless adenovirus, that vehicle has been used to try and, in a very, very similar way, to try and produce HIV vaccines. And there have been lots of other attempts as well, but they just haven't been successful because the virus is very wily, and it's very difficult to stop it replicating quickly in the body and hiding away. And it hides away, and it can be dormant for quite a long time, and then the immune system has no effect on the virus at all, and then it can pop out again and replicate. So it's kind of a combination of how the virus replicates, and also how, and the infection, and the type of antibodies that can be raised or by molecules that have been made in these vaccines. So it has been a real enigma for a number of years, and it's not been for the want of trying. I mean, there've been lots of vaccine trials, lots of attempts to make vaccines, and maybe with the more up to date technology that now have been applied to SARS-CoV-2, to COVID, um, there may be some more success with vaccines for HIV.
Right. And I'm actually glad that that question was raised because it highlighted something that's quite interesting about HIV that you just brought up, which is the fact that the virus itself hides within our cells to remain undetected by our immune system. So essentially, it's almost like a robber late at night prowling in your neighborhood. He sees the police lights coming down the road and he goes into someone's garage. The police drive by, they're unable to see him. As far as they're concerned, there's no criminal in the neighborhood. However, when the coast is clear, he jumps out and he continues to do his damage. Is that what you're really saying? Is that how it operates?
Yeah, like that, and also as well with the routes of infection, which tend to be say infection via sexual transmission.
Mm-hmm.
The virus is transmitted across mucosal membranes, usually by getting into and hiding in certain of the immune cells in the body, but uses those cells kind of like a Trojan horse.
Right.
And once it's like in that situation, even if there are antibodies around or immune cells that might recognize the virus and kill it, they don't see it. So
Mm-hmm.
by the time that they could see it, the infection has already taken hold, and it's already well underway.
Right. Right. So you spoke just now about drug resistance. Tell us more about drug resistance before we go on to our next question from within the audience.
Before drug resistance, do you want to talk? Well, I can talk about that, but do you want to talk about the actual some of the actual drugs that are used and
Sure,
combinations that are used now?
that's
So
fine.
so the common so commonly, if someone is found to be HIV positive, as I said, there's a treat all approach around the world in terms of CD4 cell counts really become irrelevant. Um, Viral loads are important, and people are offered treatment. So, for example, here and in many other places in the world now, a so-called first line of treatment would be an integrase inhibitor that's actually been quite revolutionary called dolutegravir. And this is an inhibitor that works very, very well and is not toxic, is can be combined with other drugs, and it doesn't really induce resistance very much, but we can get onto that in a minute. So those the first line is typically then dolutegravir with other drugs, but other nucleoside with some nucleosides, RT nucleoside inhibitors. So, for example, a drug called 3TC, which is a nucleoside analog, or tenofovir, which is a nucleoside analog, or a 3TC substitute called FTC. So that would be a three-drug combination, which is typically recommended by the WHO, and is a fixed drug, a so-called fixed drug combination. So one pill once a day of those three drugs. The other recommendation I know in Barbados is the same or similar to nucleosides, being tenofovir and 3TC,
Mm-hmm.
combined with a non-nucleoside called efavirenz.
Right.
And that's again a fixed dose combination WHO recommended. Probably not used so much, I would say, in the US and in Europe now, because there have been issues with the efavirenz with certain toxicities that people taking this drug longish term can't really cope with, particularly things like nightmares, bad dreams, and other things as well. So I think the favourite is really the dolutegravir, the integrase inhibitor, plus two nucleoside inhibitors in the single fixed dose combination tablet. That's first line. And what would happen then is the person who is taking the treatment will be monitored, and it would be hoped that within a few months, their viral load, depending where it started from, would start to be suppressed or go down. And certainly within a year or less than a year, that viral load would be below the limit of detection, and it would stay below the limit of detection. If there's treatment failure for whatever reason, because the person stops taking the medication, it's too toxic, which it isn't these days, but it used to. That's what used to happen, or the virus becomes resistant, then there would have to be a rethink and different medication. The medication changed and different ones used, usually as a result of a test, a resistance test on the virus to find out how it's mutated. So going on to resistance, it's interesting because it's very topical at the moment, the COVID variants, but with HIV there are even more variants, and variants occur very, very rapidly, much easier than coronavirus. Essentially, every time the virus reproduces itself, it makes variants, or variants just kind of pop up. And these are spontaneous, and they pop up because of the process of the replication. The reverse transcriptase reproduces the genome, but it makes errors all the time. It's called a very error-prone enzyme. And because of this, it naturally throws out lots and lots of mutations. Now, most of them are harmless and don't do anything at all, but some of them just fortuitously cause the virus to become resistant to certain drugs. And many mutations have been found, tens or even hundreds of mutations, not all in the same virus, but that cause resistance to different drugs or multiple resistance. So what happens is that once a person is treated, if they're treated what is called suboptimally, either they don't take the medication when they're supposed to take it, miss doses, or they only take or one drug, monotherapy, or two drugs. Well, in the old days, monotherapy. The virus suppression, it doesn't completely occur, so the viral load won't go below 50. The virus is allowed to replicate, and any of these fortuitously generated mutations that happen to be resistant to the drugs that are being used to treat the person with will then become dominant. They will outgrow, much like the COVID variants are doing now, because they grow fast. They'll grow faster than the susceptible strains and
Mm-hmm.
become dominant, and the drugs will stop working. So that's kind of drug resistance in a nutshell. And so really, it's essential. And I think I've been trying to hammer home this message for people who are being treated and are suppressed completely with antiretrovirals. It's essential to take the medications as prescribed to keep the virus suppressed and to avoid drug resistance. Otherwise, the virus can regrow, and the whole treatment regimens will have to be rethought. And at the moment, a second line regimen would maybe contain a protease inhibitor. Generally, the protease inhibitors have associated toxicities, which some are not well tolerated by people taking them.
Right.
So it's best not to get into that situation.
I'm actually very glad that you brought that up because quite often, even outside of HIV, we often see persons or patients taking medication. They have gotten into a range that we would consider the optimal target range. And then they said, oh, well, my situation is very well controlled, so I can stop taking my medication. And then you have a problem. With HIV, it gets a little bit worse in that you can potentially then develop a resistant strain. So I'm very, very glad that you really brought that up because that's something absolutely important. We have four more questions since you last answered a question from the message blog. The first one is, if it is the same PCR that does COVID-19 tests, why would we not be able to get HIV viral load results?
Why can't we get them? Sorry, I didn't quite understand that.
It says here, why would we not be able to get HIV viral load results?
Well, we can get viral HIV viral load results. I mean, they can be obtained really quite simply by viral load testing.
Right. Okay.
But the kits or the reagents have to be very specific to HIV and the specific sequences of that virus, the virus genome. Whereas with COVID, there'd be different sequences, so they'll be specific to that virus.
Okay. So you really can't really share the same kits essentially.
No, no, that's what I'm saying. Yes, I think if that's what the question was saying, you can't share them because they have different components that are unique to the properties of the genomes of the different viruses.
Okay. So I'm going to ask this question. Good evening. How common are false negatives and false positives nowadays?
With the viral load, well, with the antibody tests, very uncommon. The tests, and the same with the viral load. The viral load test, with the accuracy is in the high 90%. So the chance of getting a false negative with a HIV or RNA or viral load test is very, 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 very uncommon, and the chance of getting false positive is very uncommon as well.
Hmm.
For a number of reasons. One, because the test is very, very specific and very sensitive, but also because going back to the biological material that is used for the testing, it's more homogeneous. Plasma is a much more homogeneous, easy to use, easy to test fluid
Mm-hmm.
than scrapings from the back of the nose, if you like.
Right.
Um, so it makes it much more reliable, quantifiable, and a very, very good test where you really don't have to worry about false negatives or false positives like you really do with the COVID PCR test and,
Hmm.
and, and actually the antigen test.
Okay. I have a few questions here that are all related to each, well, sort of related to each other. We're going to talk about first post exposure prophylaxis. I'm going to take a question that's even further down, and then I'm going to go to the pre exposure prophylaxis. What is the regimen of the drugs if there's an accidental exposure to HIV? Example, if someone is raped in the space of a medical practitioner or a healthcare worker where they could be needle stick injury or even a ruptured condom.
Okay, so the I think the typical regimen is called Truvada, which is FTC, which is a nucleoside analog, and mixed together with tenofovir. So there's those two drugs, and quite possibly with another drug as well, like a protease inhibitor or an integrase inhibitor, but usually just Truvada, I think. But that would be taken for a number of days, up to a week or more than a week. But I guess you would probably know a bit more about that than me in terms of the time of that treatment
And this is
regimen. It's not
This
just a one pill.
so this is your pulse or that is your prep? Because generally
That's
we
that's the post.
that is the pulse. Okay. Um and also in terms of they have another question here. Does prep really work? Because quite often we know that there are some persons who may be living, for instance, with someone who's HIV positive. Their partner that is HIV positive may be undetectable or they're trending down. And or we may have, for instance, a sex worker or someone who just thinks that they're high risk and
Yeah,
would like to have would like to start treatment before they've actually had a true known exposure. Um, it does that medication really work? That's what someone is asking.
well, the easy answer to that is yes, absolutely. And PrEP has been revolutionised HIV actually, and the whole complete aspects of HIV and infection. Um, and it is used around the world quite a lot. And it's PrEP is basically again Truvada, which is tenofovir plus FTC, the two RT inhibitors that are very safe, that they rarely give side effects, um, and would be taken once a day or every day, I should say. And it's as simple as that. And I think that when PrEP was first proposed, there was some kind of skepticism, but looking at very rigorous and extensive clinical trials, it really works. So I would think that people in those situations that you outlined would absolutely have no reason not to take PrEP on a regular basis long term.
So I just want to go back from a clinical side now. So a person who may think that they may be consistently exposed to the HIV virus, they can take PrEP, which is your Truvada.
That's
However,
correct.
for someone who may have had an emergency situation where they've had an exposure, they're very concerned that this exposure is possibly linked to them potentially having or developing HIV or being infected with HIV, they can then take PEP, which is your post exposure. And that is medication that's taken every single day for 28 days to
Okay.
ensure that they decrease the chances of them getting the virus and actually replicating that virus. Now, clinically, that you can have side effects, as you can have side effects with any medication, but these medications are generally well tolerated. And so it shouldn't be a situation where uh, a person decides to persistently or recurrently rather take post exposure prophylaxis. These are these medications are usually used in emergency situations only. However, if it is for any reason that you may think that you are at increased risk of contracting the virus, then what one would want to do is consult with their physician and seek the possibility of PrEP, which, as you said, is the Truvada that you would use.
Yes, and PrEP, the two drugs, works very well. But post exposure tends to be the two drugs plus a stronger drug as well that you wouldn't want to take for too long.
Right.
So, for example, a protease inhibitor, because you may have been exposed to a large kind of infectious dose of the virus, and make sure that it's all inhibited and
Right.
you don't become infected. So that's a rationale for the post exposure prophylaxis.
Great. Well, thank you so much, Dr. Larder. I mean, this here has been an extremely insightful evening. I know this is not a common topic that we often discuss, usually considered to be taboo, but I think it is quite important, especially given the fact that we now know that one can live for quite a long time with a relatively normal uh, quality of life, especially when they are being maintained and treated with HIV antiretroviral medication. And we hear the term that you actually spoke about earlier, which is undetectable, which is what we really want for anyone who has been exposed and has contracted the virus. That's where we would like for them to be so that they can continue to have as good a quality of life. And so I want to say thank you so much this evening for coming out and really sharing your knowledge with us. And also, I want to say thank you so much to our listeners who decided to log in this evening. I actually saw a few new listeners within the actual podcast. So I want to say welcome. Hope to see you back. And once again, I encourage you to follow us on both Podbean and Anchor and join us next week on First Aid Chats by Dr. G. Closing the
Thanks,
gap.
Dr. G.
Good evening. Thank you, Dr. Larder.
Yeah, thank you. It's been a pleasure.
Thank you.